There we go. Well, let's see here. Trying to capture everyone. Good morning, Dr. Nota. Wearing red as well. It is the color. Yeah. Dr. Compton, do you have any red on? You didn't get the memo. Well, good morning, everyone. The December 2021 meeting of the Louisville Metro Board of Health is called to order with a cautious adviso to continue wearing one's mask in public and in group settings, and especially inside with people, being cognizant of the potential for, I guess one would call it the first new variant of the new normal, Omicron. We are being streamed live on Facebook for everyone. To the community and the media listening, if people in our community are not vaccinated, or as I say, vax times 3 or vax cubed, including the booster, please do so. We highly, highly recommend it, given the potential of Omicron spreading first to those who are unvaccinated. Please, please, please take precautions. I trust that Thanksgiving, Friendsgiving, etc., family gatherings, and all their accoutrements were both festive, but most importantly, restorative for everyone on the call. Now, I am looking just a moment. 1, 2, 3, 4, 5, 6. We have a quorum. The minutes of the November meeting were included in the meeting materials pre-read. So the chair will entertain a motion to approve, amend, or otherwise edit the minutes of the November meeting. Is there a motion on the minutes? Margaret, is there a second? May I have a second? Thank you, Paul, Dr. Vizanti. Then, is there any discussion? If not, all in favor, raise your hand or say aye. Opposed? Abstentions? Minutes approved. So as we close this year, hard to believe, we welcome Dr. Susan Buchino, recently appointed as Louisville Metro's Director of Homeless Services. But important to our discussion today, she's the author of the Louisville Metro Alternative Responder Model Research and Planning paper, which provides the foundation for a current pilot deflection implementation program being conducted with the Louisville Metro Police Department in coordination with UofL's Public Health School. Dr. Moyer, comments on Dr. Pacino, and I'm looking for her on my screen. There she is. Dr. Moyer.
I think that's a great introduction. We're happy to have Dr. Buchino here to kind of tell us about what she's been working on and what's coming up here in the future, and excited that she has joined our Metro team. So glad to have another Metro UofL partner here in the city. And so just warm welcome for Dr. Buchino.
Terrific. And so we yield the floor to you. The board did get the executive summary, and I haven't checked their homework, but hopefully they read it, because I think it provides a great introduction to your comments. The floor is yours.
All right, thank you. And thank you for having me this morning. I want to make sure I acknowledge Dean Blakely and Dr. Zippel, who are here today and worked on this project tremendously as well. So ultimately, as board members, they can answer all of your questions, I'm sure. neither of them are laughing at this, that I'm giving it to them. And I have red shoes on. I need to make sure that the red theme is carried all the way through.
From head to toe.
Mm-hmm. Yes. So I guess I wanted to just talk a little bit today. Oh, and Dr. Compton's got his red mug. Everybody's pulling out the red. I just wanted to talk a little bit about our process and what's important to the project's values and kind of where we're going from here. So early on in our partnership with Louisville Metro and 7 County Services to create, to look through best practices across the country and design a model that was specific to Louisville. We partnered also with Spalding University School of Social Work and the State Department of Behavioral Health, Intellectual, Developmental, and Disabilities. And so we've got quite a collaborative working on this together, which has really enhanced our ability to dive deep and engage the community. And so that's been our highest priority, I think, is really thinking through not only what are best practices across the country, but what really matches the need in Louisville, and embracing the community health development approach of really understanding how the community can be a part of this and sustain it. I think you are all aware of Louisville's many pilot projects that are no longer with us, and we want to get this right this time and make sure that it's sustainable because it's been supported by community and worked with community throughout the process. And so we've done a lot of focus groups, interviews, and trying to be as transparent about the process as possible. So I want to make sure that we're talking about this as a community safety approach and not something that's specific to police or one segment of a population. It's really a broad approach to community safety. That said, one of the things that really was clear is that community safety has so many definitions, and so matching a model to that, understanding that everyone needs something a little bit different to feel safe, was pretty challenging. And so we've gone through and borrowed lots of pieces and parts from other models across the country. I thought I might, if it's okay, share my screen just to show the diagram of our process and what that looks like for actually applying the model and what that will look like. So this is just a picture of how we envision the process working. So if a person calls into 911, as they would now, they'll talk to a call taker just like normal. If there are criteria met, and I'll show you the criteria in a couple minutes, then that person has the opportunity to be transferred to a behavioral health hub right here. And so when that comes to play, that's a person that has skilled de-escalation capabilities that can talk through, and 7 counties is already doing this in their call center. And so, on a regular basis, they're taking calls from people in a behavioral health crisis and able to de-escalate that situation, that crisis for that person without sending anyone on site. And so part of our thought process here is that either this person who has a little bit more skills in behavioral health specific de-escalation than maybe the 911 call taker and has more time to do a little bit deeper dive, ask additional questions, can either decide then to that caller is taken care of altogether and doesn't need an on-site response. It could be transferred to the 7 counties crisis center. And so someone else then has the opportunity to spend even more time with that person, just really working through the issues on the phone without sending a mobile response. Or we can look at a mobile response. And so the on-site mobile response can either be just DUB delegates, which is what we're calling our alternative responder program. And it could be just them. It could be that it needs to go back to police because it's not a safe situation and needs a little bit more safety and security in that way. Or it could be a co-response. And so, again, I'll scroll down in a second and show you the criteria. But basically, we're looking at the behavioral health hub, does that triage, and then figures out which one of these responses is necessary. And with hope that takes some things directly off of the plate of other responders. But we also have the opportunity for a co-response. And so when we looked at these criteria, we also were very thoughtful not only about what is safe, but what is liable and what is the data saying, right? So we had 911 call data and look through that. Our specific task was to look at CIT events, and CIT is the crisis intervention training that all LMPD officers receive. And so they do receive 40 hours a week of crisis intervention training, but any behavioral health events are then labeled CIT. Now, what we found out as we were looking at this is that what comes in through a call is not always what then the responder sees on site. So there's some differentiation there that we're not going to always be able to predict. And so the call takers do the best they can. The behavioral health hub will do the best they can. But still, we know that looking at the narratives from the CIT calls that we received from MetroSafe, that's not always what the scene looks like upon arrival. We also know that codes don't always get switched. So if something is labeled CIT in the data, it might not, and then the responders, which right now are mostly police, get there and it's not a CIT event after all, then it might not get switched in the data and vice versa. So if the police arrive on a scene and it really is just a behavioral health crisis, that doesn't necessarily get recoded. So our data aren't perfect. And so we used them though, and the narratives to really look for keywords and issues that were happening that we could make some clear decisions on criteria and what would warrant a response from the DUB delegates mobile team. And so right now we want to focus on adults. We know that children have crises as well, but they need to be managed a little bit differently. So if there are clearly no weapons on site that we know of through the call, it's not a medical emergency, and there's some safety anticipated in that situation, it's a very clear call for a DUB delegate's response. That said, if there are any indications of safety, including weapons and violence, that really just warrants a police response as normal. But we also know that there's a whole lot of gray area that's not well defined and clear cut. And so part of our pilot will be really honing down on what else we can deflect easily, but also having this opportunity for a co-response where if it warrants that police are there to clear the scene for safety first, oftentimes they do get there thinking it might be an unsafe situation, but once they arrive, they determine it's not something that they need to, it doesn't warrant law enforcement of any kind. You know, their tools are really to bring someone to jail or to the hospital. And so instead they can be on site, say, we don't need to do jail or a hospital, nobody's really unsafe, and we can pass this off to the DUB delegates responders. And so those responders will be people who are also skilled in de-escalation of crises. We are still looking at what additional training, for example, medical training, you know, if they need to be trained as EMTs, that might be a future iteration of this model. But essentially, they'll be on site to help take care of the situation and connect the person to further resources. So they will be able to transport if that is necessary, and be able to bring someone to a lower level of care or a safe place if that place that they're in currently is not safe. And so operating a little bit differently than what currently happens from an emergency response system that has very limited options of where they can bring people and how they can respond. So I'll stop sharing that. Let's see, we were intentional about starting with behavioral health, but we also know that there are lots of non-law enforcement required emergencies that exist. And so really we want to build a network of providers in the future so that it's not just limited to a behavioral health response. We know that lots of people are already in our community doing the work to respond to crises. And so we want to make sure that we're enhancing that system, resourcing the people who are already doing the work. And you know, our primary goal is to ensure that people feel safe and are safe. Also, I was just gonna stop there for a minute. And so I'll tell you a little bit. Our pilot program, we're in the hiring process right now. 7 counties is working on that. And we heard repeatedly from other programs that start small, figure out what works, and make adjustments. And the beauty of what's happened in other communities is really has been their evolution. And so when we start this next phase of people actually in the field and doing the work, we're going to start in one police division with one team on the ground and build from there. So our MetroSafe data really indicated that we should start in Division 4. It's Central Louisville, Old Louisville. There is a lot going on there. It's a very diverse population that lives there, diverse in terms of what businesses and residential kinds of settings exist in that situation. So we have a lot of opportunity there to really learn. But eventually this will become something that's that is countywide. So that's a really high level overview of what we've done. What questions do you all have about the process or where we're going from here?
So let me frame this a little bit more and ask Dr. Zippel and Dean Blakely for comments and comments clearly from the board, rather than barrage you with a series of questions that I have. Give us a time frame, if you will, for this getting off the ground, and is there an evaluation mode or a model that's being used? And I'm sure there is, given you're a professor. This is an academic effort in part. And sort of just time frame it for me. and sort of work plan it with the milestones?
Right. So we are, I think, now shifting a little bit to hopefully start with a team on the ground in February. Timing is everything. And as we all know, the economics of hiring right now are all over the place. So 7 counties has posted the positions, and as soon as they can get them filled, to start with that first team, those individuals will go through training, and we're still, so the team ultimately is working very close with MetroSafe to design policies and procedures, because the behavioral health hub person will be situated in the 911 call center. So they've had to be a really close partner in this and trying to put together the logistics. So some of those things still are in process and design. But beyond that, rather than it being a pilot with a full evaluation, we have an evaluation design. But because we're starting so small, we really want this to be a data-driven evolution and development process. So I'm hesitant to call it then a pilot with an evaluation, because ultimately we're not going to have a year from now a specific, we did this for a year and then here was the outcome. We want to make changes as we're seeing them in need, and make those adjustments continuously based on the data that are coming in. So we have a number of metrics that we'll be able to look at pretty routinely, like on a monthly basis, and then make those adjustments.
And how large is the team?
So it's a 2-person team on the ground that would be doing the mobile response. And I believe 7 counties is looking at hiring 12 people right now. We start from 10 a.m. to 2 a.m. as those 2 8-hour shifts. We would love to get it to 24 hours as soon as possible. With that one team in mind, again, we're really looking at a capacity issue and the ability to hire a full team. And so there will be a couple people who would be able to fill in that behavioral health hub spot. And then we also have clinicians that are supervising. I think it's important to know that neither somebody on the triage line does not have to be a licensed clinician to be able to do that de-escalation work and that triage work. It's very specific training, but it's not necessarily a licensed clinician. And we really want the people who are going and doing the mobile response to reflect the community that they're responding to. And so while we want people to be well trained, it doesn't mean that they all need to be licensed clinicians. And some communities do that. Other communities have used more peer supports. The largest and most well-known model right now in the country is Cahoots out of Eugene, Oregon. And they advise us that bartenders are excellent because they're naturally de-escalating situations all the time. And so having people in the community who are doing the work, but then could come into that team is really important. And that's why we really want to build a network of providers.
So we're recruiting bartenders into our MPH program aggressively now, right?
Yeah.
That's good. And they work out of one of our Bourbon Trail distillery. That was fascinating. That was counterintuitive.
Heidi, let me make a couple comments.
Yeah.
So one thing I think that Susan sort of alluded to is that everything we've seen about successful programs, not just Cahoots, but others as well, is that you don't develop a program, put it in place, and it's there and it works. And we've learned plenty of that in Louisville, where we try pilot projects and they don't succeed instantly and then they just disappear. And so as Susan was saying, we're really trying to uh, frame this as an evolving set of development activities that will lead to a program down the road. And even 3 years from now, there may be things that still need to evolve as community changes, et cetera. And that's one point of contention that we've got working with the city is they really want this. They see it now as we've got a program model, we're going to implement it, and there's going to be this independent evaluation. And so we've been arguing about, no, that's not really where we are yet. So that's going to be interesting to watch to see how that evolves. And of course, we're looking at a meaningful year of that evolution occurring, and then all of a sudden there's going to be an administration change. So, you know, there's another whole political overlay that's going to have some influence on where this ends up. So I think it's really, you know, we have a great opportunity, I think, to put something together. The other dimension is this is kind of a 911 call center, very specific set of deflection diversion activities. On the other hand, there's this big, huge picture of what is public safety in the community that's been heavily politicized and impacted incredibly by the last 18 months of activities across the country. And somewhere those two things need to coalesce and evolve together. We can do this 911 deflection project kind of in a vacuum and put, I think, out some great outcomes. But it could be also a part of a system intervention that leads to other kinds of things happening on a much broader scale. And it's not clear that the team that's trying to make this work and the city are on the same page there either. And that's not surprising, but those are political realities that I think any kind of support that can come in from anywhere to keep in mind that this is a specific project happening in a much bigger evolution of things. I think that's an important way to frame part of what's at stake here.
And just to build on that, you know, I think that Craig is exactly right, that the most interesting parts of evaluation on this are going to have to do with the city and the community's ability to execute. The intervention structure itself is well understood. You know, in behavioral health, we've been doing this kind of intensive outreach to populations like this for more than 40 years. So there are versions of this all over the country, frankly, all over the world. So it's really well understood that you can do this and how to do this. There's lots of experience with it. The challenge is, how do you take that knowledge and map it against an existing community and get the community to take up the mantle and go and make it work? And that, I think, is going to be the challenge and the great learning for all of us as we do this.
One final comment, if I might. I want to thank Susan for all the work she's done on this. She got dumped into this role, not exactly kicking and screaming, but just as the person on our team that was most well positioned to do it. As you alluded to earlier, Sarah, she's now taken on a very visible role with the city in homeless services and created a conflict of interest so that she really can't be the same point person on this project anymore, but will be involved in the project moving forward in her new role with the city while staying on board as a faculty member doing other things, of course. So that evolution is going to happen as well. You know, it's very clearly the case that a lot of these calls that come into the call center are linked to homeless kinds of issues anyway. So I think it's going to be a nice transition. But thanks for everything you've done to date, Susan.
Ms. Handmaker.
Good morning. So I have some influence with the city. I might be able to help, but when you just refer to the city, who are you having trouble with?
Susan's looking at me to answer that, I'm sure. Well, the real issue, I think, Ellen Hessen is kind of the point over what's going on. I think we get along fine. You know, she in and of herself is not a barrier. She's in the position, though, that is responsible for overseeing what's going on. Then there's a handful of people linked to operations in the call center who, you know, I think are dead set on where it's going to be housed in the long term within the infrastructure. And you know, my personal bias is when you've got an infrastructure in place already, your first reaction in putting a new program in should not be to create a new separate infrastructure. It should be to see if you could make it work within the existing infrastructure. And so we're trying to do that. But most of what we've seen in other communities suggests that a different silo might be better, that's got more ties to community directly if you really want this to be embraced in the community. So that's one of the conflicts that's out there. I'm hoping that right now is not the place where that decision is being made, and the evolution that's going to happen this next year will allow us to move forward on considering where might be the best place to house this. Clearly, it's got to be tied to the 911 call center set of operations. You know, I think another thing that should be said is, and this is not speaking directly to your question at all, but just occurred to me. When we go to scale on this project, we're going to bring in a whole bunch of other providers in addition to 7 county services. That's where we started because that's the biggest, most well-established hub of services with a crisis call center already. So that's going to add a whole nother level of complexity down the road as we start moving to scale. But you know, I think I would love to be able to call you back and have a conversation about this when we do bump into problems.
Okay, so Matt Golden is really the point person on this.
Yeah.
He's highly supportive. He's asked me for funding for this. I'm highly supportive. We tried to do something like this 10 years ago. And the people at EMA are highly supportive. I don't think you need to run into any problems, and I'd be glad to help you. Everybody's really supportive of this. Where it's housed, I think I agree with you that it shouldn't have been an LMPD in the first place, so that was a good move. And yep. I'm much more optimistic than you are.
Oh, I'm not pessimistic. I just think there's going to be skinned knees along the way.
Yeah, well so this is how we do it, though. If it doesn't work, you fix it. You stop doing something that doesn't work. You learn every week. You change it. You modify it. I think that's the culture now within Metro government. So I don't think there will be any problems with that.
Where is Matt Goldman housed in city government?
Matt Golden is he's in charge of actually I don't know what his job title is, but he has all sorts of everything public safety as well as EMA.
Yeah. I mean, Margaret, you may well be right, and I think you are right that at high altitude, everybody's been really supportive of this. The challenge comes down to as you dig into the details of it, and how do you actually get the gears to interconnect? You know, decisions like what's the level of risk that we're willing to tolerate in this program? For this particular call, are we willing to take this on, recognizing that there's no guarantee about the outcome? We could refer it out to the mobile outreach team, recognizing that the outcome might not be great. We could move it over to police, recognizing the outcome could not be great. The challenge is, how do we make those decisions, recognizing that it's an imperfect world? And when you get down to that level of detail, it takes intense work to make sure that this is all going to happen in a way that continues to move the project forward. So I agree with you in principle. You're exactly right. We'll see how it plays out when we start to work in the nitty-gritty details.
So one of the things that Dean Blakely just mentioned was that it has to work through the 911 system, and that is not necessarily true. Sorry, Craig. There are other communities that have created their own line. So you could call the 7 counties crisis line directly and get a mobile response in a situation in another community. So, you know, if that's not the best place for it to be, it can also be there. 988 is coming as well. So I don't know if y'all are all familiar with the 988 system, but it's a federally mandated number, 988, that is instead of 911, that links people to the national suicide hotline, and that needs to be implemented by July 1st of 22. So Kentucky as a state is working on that. It's implemented at a local level. And so we're hoping that eventually then part of this evolution is getting to that no wrong door approach, where it is a broad-based way of accessing assistance. But there are so many ways to tackle how to get there. And I think that's important to know. And, you know, one of the things that we've talked a lot about as a coalition and what I think brings us strength is that the community does not trust institutions right now. Not any, right? Not government, not UofL, not 7 counties, and not Spalding, and not the state,
and not the Board of Health,
and the board. Like it's a trust issue. By having us all together and creating a community accountability board, and we were very intentional about it being an accountability board, not a advisory board. We are hoping that we are bringing trust to the situation so that people do trust this process. That said, if it becomes, you know, if we're not listening to the community, that's where, and responding to community needs, that's really where we're going to continue to have trust issues, and people won't use the system either. And that's where it will get stuck.
Let me open this up to the board as a whole for questions. Thank you, Margaret. So let me, as we look to wrap this part up, one important role of the Public Health Board, and a way in which I think we can be trusted. We're probably trusted more than the folks you listed, but is in public policy advocacy. So, and for those of us who come from the business community, connecting you with, connecting everyone with resources as necessary, and those of us in the health business or with health experience can certainly provide any collateral support. That being said, is there something in public policy that is missing? Are there opportunities? Will those opportunities, they may come to light as the program moves into more mature levels. But anything immediately come to mind? And were there those kinds of changes in leading communities similarly situated as Louisville?
I'm not thinking specifically on public policy things.
I think what's interesting about this is it's the point that Craig made earlier that you know, this is one component, and there are lots of other components that matter. When you think about the whole array of things that we need to do this is one piece, but there are also issues in terms of availability and access to community services that are important to us. There are issues of how we handle things in jail and in corrections that have implications for this. There are issues about how the courts operate that have implications of this. This is one really important pillar in it, but there's a whole range of public policy and practice issues related to criminal justice, public safety, and disability rights, that intersection that we can do better with.
Okay, that's good. And probably what's good is to compile a list of the component parts where additional focus needs to be placed and or resources needed, because that's what some of us can provide at the table. here. And so we will definitely have you back if there are no other questions. Just for updates, clearly a thanks to Dr. Zippel, Dean Blakely, because I think this has enormous promise. And anything that starts with the grassroots and not the top down has, at least in the chair's opinion, the greatest opportunity to succeed. And my one takeaway probably for the week are bartenders. That is both memorable and highly insightful and instructive. So thank you very much. And I would say good luck in your new venture, and your experience should give you great opportunity for success. Thanks.
Thank you. I appreciate you all having me today.
Great. Okay, let's see. As I had mentioned in my update, we were going to hear from Sarah Weibel, who is the head of the Kentucky Immunization Registry. I made a comment in the beginning, or maybe it was prior, just in conversation, that I am out of state and went to an event with my vaccination papers, a photo on my iPhone, and the actual vax card copy of in my wallet. I was the only one who didn't have a smart card and a digital code. And Kentucky is joining the smart card network, and we had invited her, but there was a system glitch with a vendor, and I call it a glitch. I don't know what kind of, we would say, kerfuffle there was, but nonetheless, there are cities that have vendors where this is not the case. So anyway, they are scheduled to come back to talk to us in January about having a QR-coded smart card that one can use anywhere, and they sure are helpful. It's just where, as a community, we need to be headed in the area of health, and taking advantage of digital technology and not waiting for someone else and working through bureaucracy as much as we do. But yes, I'm cantankerous, and this has hit a nerve with me. The chair's update was contained in the pre-read, so I'm going to forego that because there's no other news from me at this point. So we turn to Dr. Moyer for her update, which was also contained in your pre-read. Have asked her to cover two things. The first being the latest update from the federal government, CDC, and the state on Omicron and sequencing and what we're seeing in the community, as our rates are really high, given maskless children in school and people thinking that it is possible to go back to normal. And there is no normal. I think everyone on this call knows there's new normal. And then to focus on insights from other department priorities in the next couple months. And then there was an article in the Courier Journal recently on, I don't know how to say it correctly because I've never had to say it, but a Rubbertown chemical company, Chemours, with regard to emissions in Rubbertown. And so Connie is here. There she is. Welcome with her red cup, keeping our mantra going. New developments in Rubbertown relative to emissions from that article. So Dr. Moyer, I turn it to you, to Connie, to whomever.
Sure. Well, thank you, Heidi, and thank you, board. It's been, another fun month. Got to experience COVID personally with my family. So it's been a month. So updates besides the director's report, please take the time to read that. The executive order for the city that extends the state of emergency has been extended another month because we are still in the red here for COVID. We dipped down to orange again late last week, but it was just because of the holiday week and the shortened amount of time for testing and reporting. Cases are back up this week, having not record highs, but we're back to July, October numbers for the positivity rate, as well as levels of COVID in our wastewater. So we know we're back up on that upswing. And then with that, the Omicron, another new threat. So the WHO declared that a variant of concern over Thanksgiving weekend, which means that it's more severe than a variant of interest, but less than a variant of high concern. And this is thought because the mutations raise concerns about faster spread and possible vaccine evasion. We don't know yet, it is still too new, but some of the mutations that Omicron is seeing are shared with earlier variants that showed vaccine evasion, but didn't spread well. So we're studying that. I think at the epicenter of where Omicron was first found or identified shows that majority weren't vaccinated, and then the rest were only half vaccinated. So with that, just brings extra importance to getting vaccinated and to getting your booster. The CDC did change recommendations that everyone over 18 should get a booster. This is different. Previously, it had been they may be able to get a booster. And so now recommending anyone who's been vaccinated, if it's one of the mRNA vaccines, it's 6 months post your first 2 doses, and with the J&J, it's 2 months. So make sure everyone knows to get that booster dose right now is a great time, even if Omicron is not here. But that said, also too, it's just another reminder that layered protections are so important. Vaccination is just one tool. So just make sure ventilation, masks, and then testing. We are seeing a significant number of breakthrough cases. While they tend to be mild, about 25% of our deaths that we have are fully vaccinated with those 2 doses. So especially with the holidays coming up, if you're going to be around family members that are older than the age of 65 or anybody with an immune compromised system, please test even if you are fully vaccinated, because we are seeing spread happen just because it is so prevalent in our community now. I think that's it for COVID. Other priorities for this month is really finalizing our asks for the ARP funding and working with the city on that. Our priorities go with our strategic plan for the next year and a half, which is really need a new EHR data management system, as well as new building and better workspace for our employees. We'll be submitting a few programmatic ideas, but those will be second because we can't serve the public well if we don't have the right tools and we don't have the right space for our staff. So those are the big things we'll be asking, and we'll see what happens. I know a lot of the money has already been designated, and some great things are coming out of it with housing and childcare and other stuff. So I'm excited about the direction, but as a health department, we're going to be asking for EHR and building, and hopefully we will get both of those. LMG did announce that the mid-year surplus was going to be going to some of it going towards improving salaries. I know that was a big part of our bridge plan as well. So hopeful that this includes our team, but even if it doesn't, if we can get better and more people in our centralized services, I know that will greatly help with some of the headaches, the daily headaches that my team faces that are leading to burnout as well. So positive news with that. And then other positive news, the team got their first payment of the premium pay. And so I know that was something that was questionable for a while. So I'm glad that they were able to get that, especially in time for the holidays. And then lastly, just looking at my calendar for the month, City Health, which is the group that gives out medals for passing policies that impact health, will be in town next Monday. So we will be meeting with them. They will be announcing, not next Monday, the 13th, so 2 Mondays from now, but next week they'll be announcing the medal winners for 2021. We did receive a gold back in 2020, and so hoping that that will continue and get another medal to add to our shelf. But they also are expanding it. So I think they're going from 10 to 22 policies. And so going to be meeting with them just to see how and why they picked what they did and what might be a good fit for Louisville going forward. So more in store there. Besides that, just hoping people actually get time to rest and recover over this holiday season so we can get back at it in January. Any questions?
Perfect.
Before I turn over to Connie to talk about air pollution.
Perfect. And a shout out, as always, to your hardworking team, and a big festive hug, and the regeneration, refreshing, spending time with friends and family. Being one of the few non-clinical people on this call, or maybe I am clinical in a different way, is really, really, really important. So thank you for all that the team does. Ms. Mendel.
All right, good morning. So I am certainly not an air pollution expert, and I would recommend anyone who is interested in the subject of air pollution. The Air Pollution Control District does post their meeting minutes on their website. Those are easy to return, easy to access, and plenty of information there. So with air pollution control, it's complicated to say the least. So the shortened version is that there was a compelling article Jim Bruggers wrote in regards to Chemours plant, which that is a spinoff of DuPont, which has been a long-standing company in the Rubbertown area. They, due to new regulations to reduce greenhouse gases, will be collecting a product which is HFC 23, which is a huge contributor. It's a huge greenhouse gas contributor to ozone issues and everything else. So that is a byproduct of something they create or that they need. They need HFC 22. It's used a lot of commercial residential uses, air conditioning, and you think of DuPont historically of Teflons and different products, ones that we readily use, but unfortunately there are a lot of emissions created from the production of these products. So the HFC 23 is a byproduct of that, and currently is just being released into the atmosphere, not considered an air or toxic pollutant, but has a greenhouse gas issue. So they'll be collecting that and then shipping actually quite a bit of that off to West Virginia, where it will be incinerated. And in the collection, chloroform is produced, and they use chloroform in other product lines, but there's a potential for chloroform to be released in the collection of this product. They are already currently permitted by the local air pollution district, and chloroform is one of those things that they do have a permit, which means they are allowed to release amounts, and that is a maximum yearly permitted amount, so it can fluctuate. In looking at the models and everything, it should be very small amounts, if any, as far as releases, but there's no guarantee on that. I agree with one of the people interviewed in the story that they should not have to trade one chemical for another as far as released in the community. And absolutely. And it's interesting, at APCD, regulations that they have in place are by far the most stringent, most restrictive. When you look at national regulations, that's their STARS program that continues to be some of the most restrictive in the country. But this and also kind of goes back to the conversation that Susan and others had mentioned. There is a lack of trust between whether that's the residents in that area with the air pollution control district, governments, obviously manufacturing facilities, and so these conversations are typically very difficult, and just the back and forth. I know that, like I said, APCD's spent a lot of time on that. They have a lot of information on their website. I'm welcome to share some of that, with anyone interested. But given that, so there is the potential of more of a chloroform release from that Chemours plant, but that more would still be within their permitted amounts. But it's not expected, but accidental releases happen. So that's a little bit of of that. I'm happy to try to answer any questions, if that made any sense. Hopefully I didn't make it more complicated.
So before I open it for questions, you did make a recommendation. Thank you for that. At a future meeting, we, if the group desires, can have someone come and talk to us about the compounding issue, if you will, in, no pun intended, in Rubbertown, and what goes on to the neighborhoods around there, and whether or not there's the kind of neighborhood participation and voice that Dr. Buchino mentioned in the public safety initiative. So I think that was a good recommendation. Questions from the team, the board? Well, let's keep it monitored. And is everyone in agreement? You can wave at me or whatever, to have some folks come sometime next year to talk about Rubbertown and this particular issue. Are we good with that? I'm seeing nodding heads. So, Connie, Dr. Moyer, I think we'll go with it then. Okay, thank you so much. Appreciate it. I don't see anyone from the public school system on. Is there someone from Eva, Angela? Okay, Dr. Briones Pryor, let me find you. There you are, the corner square.
Yep.
Sharing GLMS.
Sure, and I don't have much of an update, and the reason for that is because this Saturday we're going to be doing our strategic planning to set our 2022 goals. Dr. Moyer has been invited to be part of that with us, so hopefully in January I'll actually be able to share with you what our 2022 goals are, but right now,
fabulous.
We're going to be planning them this Saturday.
Perfect, perfect. Thank you. Shelby Williams, who is the Public Affairs VP for GLI, is unable to make every other month, but said that GLI will be releasing their public policy priorities for 2022 for largely the legislature, the state legislature, in the next probably 10 days, and we will share that with you. She'll be back in for our January meeting. In terms of committee reports, I know you join with me in congratulating Dr. Emerald Eccles on birth of a child. New bundle of joy to her during holiday season, and she'll be back with us in January as well. So with that, Dr. Owen, Ms. Shoemaker, you are the floor is yours for coverage outreach and any update from Family Health Centers.
Okay, so we are in the midst of open enrollment. Today is the last day to change managed care organizations for Medicaid. Medicare open enrollment ends on December 7th, and the qualified health plans ends on January 15th. It is an interesting open enrollment so far because we have moved back to Connect. We're all on one system again. And so our next coalition meeting is scheduled on December 13th. And we'll take a look at our numbers and where we are so far in terms of open enrollment and what more we can do to help reach some of the hard to reach populations.
Are we hearing any feedback from that enrollment, from the enrollment process or anything like that? And by the way, the qualified plans would be Think Exchange.
Yes, the exchange. It has, I've been in weekly meetings with the state and with the program developers of Connect because we've moved back to it's an old system, it's Connect, but they've revamped everything. So there have been some challenges, some technical issues that have, I think, kind of depressed the numbers. But I think there's a lot of interest and a lot of people are excited to sign up, especially because there are still some extra tax subsidies because of ARPA.
Okay. Dr. Irwin, any insights from family health centers as a whole or what you're seeing?
Yeah, I don't have much to add to that. I just want to mention that we've been successful in getting 92, almost 93% of our staff vaccinated. We still have some who are not, and we have a federal mandate to come into compliance with all of our staff being vaccinated by the 5th of December. So that's going to be very challenging. We've lost one person so far because of that. Hopefully we won't lose anybody else.
Okay. And I guess everybody will be seen in federal court on stopping the mandate, but we won't go into that. We'll say politics for the junkies. Thank you very much, and for all the work that you and your team do. And so now, Dr. Zippel, Spire, and just as an advertisement, a pre-ad for the January meeting, Dr. Zippel is going to share a very interesting pilot. We're going to have as many pilots as UPS shortly. Anyway, a pilot for youth in the area of adverse childhood events that I think is pretty exciting. And I gave a little tip to, or a hat tip to Dr. Briones Pryor in her position at the Medical Society, and probably Dr. Nota, a forewarning to you in terms of pediatricians and in terms of this particular pilot. So, Dr. Zippel, the floor is yours.
Yeah, thanks, Heidi. And that's really the only news I have to share. We'll talk more about it next month. But my colleagues and I are going to be proposing that we sponsor a small pilot designed to make adverse childhood experience measure a part of standard intake and assessment in health and social service programs. So we're going to be looking for a couple of locations in which we can do that. With me next week will be Shannon Moody from Kentucky Youth Advocates, who is their Director of Strategy and Policy, and Kelly Singletary, who is a psychiatrist here in town, doing the presentation, talking about what we'd like to do and the kind of support that we'd love to see from the board as we move forward with it. So more to come with that next month.
Very exciting to join the assessments of children, of youth, to join height, weight, blood pressure, etc. I think there is an opportunity for innovation here and for some very good collateral partnerships. So hats off to you, Dr. Zippel, and the committee for bringing this forward, and we look forward to the January meeting. So with that, I'm going to turn to the board for the easy part, which is any announcements from the groups you represent, any insights from your work over the last 30 days, what you're seeing out there, and issues. So go forth and speak.
Good morning. I just want to let you know that last night we have a Facebook Live event in Spanish to educate our parents of JCPS and Newcomers Academy on the vaccines, on the COVID vaccine for children. It was very well taken.
Wow.
We had great questions from the parents. And I want to thank you, Dr. Moyer, for your message in Spanish. That was very greatly appreciated.
Yay. How many people came, Dr. Noda?
It was a Zoom meeting with Facebook Live, so I cannot tell you exactly how many because I didn't have access to that information. So people were asking questions on the chat in the Zoom, but in the Facebook Live part, I don't know for sure. But we got good questions from the parents in regards to the safety of the COVID vaccine for children 5 to 11, when to vaccinate a child who tests positive for COVID. Is the vaccine safe? We were Dr. Ramirez with UofL, Dr. Patricia Cervera, who is a pediatrician graduated in Mexico, who is working with La Casita Center, and me. So we gave an overview on COVID symptoms in children, why the vaccine is important. And Dr. Ramirez talked about the variants, the Delta and the new variants. So I cannot tell you exactly the number because that was a Facebook Live that people were posting questions there, but it was very well attended.
Perfect, perfect. Shout out to the group for organizing that in a very vulnerable population. Others, please.
Hi, good morning, everyone. Sorry, my camera's not on, but I'm in clinic. So one of the things that we are working on right now is there was an article that was published recently by a local journal called A Victim Twice. And it was basically about how a patient was involved in a gunshot wound, and then because of lack of resources and where they lived, had limited access to home health services, and basically had to come back to the hospital numerous times and has gotten sicker and sicker because what we found out is that many home health services won't go to certain neighborhoods where our patients disproportionately come from that are victims of violent crime in order to receive care. So we at UofL through the trauma department are looking for really community engagement driven ways to get access to home health services. Center to
Sorry, you're fading out.
Sorry, my phone just went off. And hopefully partner with some community organizations and hopefully a formal partnership with one home health organization in order to provide these services, because we're finding that if you live in a certain zip code, you simply don't have access to home health because they won't come to your home right now.
So Dr. Miller, I am looking at Dr. Moyer, and then if there are other resources that are needed, if you or Dr. Moyer would let me know, I will make some connections as well.
Thank you so much.
Thank you for sharing. We miss your face, but understand that you're in clinic. Thank you. Others? Is there any new or old? I'm sorry, go ahead.
I'll say that, partnerships are really key to us achieving our goals as a community. Last night I had an opportunity to go to the Shawnee Cultural Community Center, and they were doing, vaccination shots and booster shots, and having conversations around AIDS and HIV. Really great opportunity for the community to come out, and it was a combination of UofL Health and as well as the VOA and Norton's, and so that team approach, I think, really helps. So I want to, encourage us to continue that collaboration because that's what it's going to take to get our community where we need from a health standpoint.
I second that motion and third it. The biggest insight I've had as a native Louisvillian, and it's a positive from the pandemic, is that collaboration among the sectors, and you mentioned many of them, Dr. Compton, from academia to social services, to the private sector, to the funders, to the neighborhood groups, to the faith-based institutions, coming together. And we need to take that insight and, as you rightly said, move it forward, whether it's Dr. Buchino's, Dean Blakely's program, which is our program, the community program, or whether it's whether or not the chemical company in Rubbertown is working with the neighborhood that they're exposing. That probably Ms. Johnson, Natalie, will come at me like the Humana lawyers did when I just sort of said what I felt. But that's the way we begin to understand where everyone's coming from, and we don't have disinformation. So thank you for making that point, and because I think it's really important. Others? Let me see. Any old business? Any new business? So the next meeting will be January the 5th at 8 a.m. It's virtual only, and it will be focused on adverse childhood experiences, led by Dr. Zippel and a team, and hopefully there'll be great news. And if I can, by the way, Dr. Zippel, help in any connections there, I'm happy to do so. Any other comments from the group? Otherwise, the chair will entertain an end of the year motion for adjournment. And as I mentioned during Dr. Moyer's presentation, a huge, huge virtual hug to the entire team and to her for bringing us to this point. And get vaccinated, boosted, etc. Motion to adjourn. Thank you, Paul, Dr. Grisani.
So moved.
Second. Thank you. Thank you. So we sort of have that. And so with no further ado, happy holidays, everyone. Take good care. Appreciate the input this morning. We should sing or something. Take care.